Hello and welcome to this new RPTH Research Recap, where we dive a little deeper into the science being published at RPTH. I'm Dr. Yazan Abu Ismail. I'm a classical hematologist and assistant professor of medicine at the University of Utah and a social media associate editor at RPTH. I'm very pleased to introduce Dr. Walter Ageno. He is a professor of medicine at the University of Insubria and director of the Emergency Medicine Unit and the Thrombosis Center at the Hospital of Varese, Italy. He's a renowned expert in thrombosis, leading multiple international committees and trials and guidelines on thrombosis prevention and treatment, and currently the chair of the Research Center of the Italian Society of Vascular Medicine. He's a deputy editor of Thrombosis and Hemostasis and an associate editor of the Journal of Thrombosis and Hemostasis. He recently published a paper in RPTH titled Venous Thromboembolism Secondary to Hospitalization for COVID-19, Patient Management and Long-Term Outcomes, which addresses a very important clinical question and a common one, and was very highly praised by our editorial board. For those joining us live on Facebook, Twitter, and YouTube, please leave your comments below, which will be answered during the discussion. Dr. Ageno, we look forward to hearing your presentation.
Thank you so much for the introduction, and thank you for the opportunity to discuss this study that was planned immediately after we realized that venous thromboembolism was a major issue during the pandemic. Please allow me to start with a very short background. You're all aware of how much venous thrombosis has been a serious complication of in patients hospitalized for COVID-19. This became quite clear to every clinician during the first weeks of the pandemic. But then after we started to treat these patients, another question came back to us, which was how long should these patients be treated for? Because on the one hand, patients with venous thrombosis related to hospitalization for COVID-19 clearly had a provoked event, which means that they should require a definite treatment duration, usually 3 to 6 months. But on the other hand, some evidence came out suggesting that late cardiovascular complications do occur in patients with previous COVID-19 due to a persistent subclinical inflammation. And some distant events have been reported, cardiovascular events, arterial events, but also pulmonary embolic events, even months after COVID-19 disease. So this, in a way, rose the question on whether these patients may have needed a longer duration of treatment. So because of this uncertainty and because of the lack of evidence on the optimal duration of secondary prevention of venous thromboembolism in these patients with COVID-19 associated VTE, we decided to start a study with the aim to compare baseline characteristics, management strategies, and long-term clinical outcomes between patients with VTE provoked by hospitalization for COVID-19 and with a control group represented by a cohort of patients with VTE provoked by hospitalization, but for acute medical illnesses that, of course, did not include COVID-19, so for other acute medical illnesses. We designed an observational cohort study, and we started to enroll COVID-19 patients with venous thromboembolism from June 2020. So after the first onset of the pandemic, which in my area started at the end of February 2020, as you may recall. And we continued to enroll patients until December 2021. And for the control group, we selected patients who were enrolled in a ongoing prospective register on patients with venous thromboembolism that is up and running in Italy, the STAR2 prospective register. And we identified those patients who were included in this register with VTE secondary to hospitalization for an acute medical disease between 2018 and January 2020 to make sure to exclude at least as much as possible patients with COVID-19 in this control group. We excluded other patients with other indications to anticoagulant treatment and patients, of course, with other provoking factors, as well as patients included in trials. We aim to have a follow-up of at least 12 months after treatment discontinuation. And we identified as a primary clinical endpoint the occurrence of venous and also arterial thrombosis while on treatment and also off treatment. And as a safety endpoint, major bleeding according to the well-known ISTH definition. At the end, we enrolled 290 patients with COVID-19 associated venous thromboembolism and 300 controls. Actually, we had to exclude some of these patients, 12 for exactly 12, because some were lost to follow-up and 3 withdrew their informed consents. So in the end, we had 278 patients with COVID-19. Now, you can see some baseline characteristics reported here. We did not we did not have a formal comparison, just a descriptive comparison between the two groups here, and you can see that more controls had previous VTE, as well as a history of major bleeding, whereas the prevalence of severe renal failure was similar between the two groups. Body mass index was also similar, and the mean age was similar between the two groups. But in the end, there were more risk factors for VTE. You can find more details, of course, in the published paper in the controls than in COVID-19 patients, and I think this is an interesting matter of discussion. As we now know very well, patients with COVID-19 associated venous thromboembolism tend to have pulmonary embolism as a manifestation of the disease more frequently than other patients. And in fact, as you can see, nearly 90% of COVID-19 patients actually had pulmonary embolism as opposed to a quarter of controls. For the initial treatment, if you look at controls to begin with, you can see that majority were started on direct oral anticoagulants from the very beginning. About 1/4 were started on low molecular heparin before being switched to direct oral anticoagulants at discharge. COVID-19 patients were less likely to be started on direct oral anticoagulants. As you may remember, we were very concerned about drug-drug interactions in these patients and about the potential efficacy of direct oral anticoagulants, but also there were initial signs, at least, that low molecular heparin could have been the drug of choice, not only for the management of venous thromboembolism, but to also improve the outcomes in these patients. So for different reasons, majority of these patients were started on low molecular heparin. Actually, this was also suggested by some guidance documents from international societies. But after discharge, also these patients received direct oral anticoagulants in the majority of cases. Now, the duration of anticoagulant treatment was actually longer than you could expect in patients with provoked events, not only in patients with COVID-19, for whom there may have been some uncertainty for the same reasons that I mentioned at the beginning of my presentation, but also in controls. And you can see here that a substantial proportion of patients with VTE secondary to hospitalization were still on treatment after the first 6 months after the index event, and this was the same also in patients with COVID-19. Actually, this was not unexpected, since this was also observed in several other registries such as the Rieta registry or Garfield registry, which also report a longer than expected duration of treatment for the secondary prevention of venous thromboembolism in patients with provoked events. And these are the outcome events in our study. So we wanted to see if there were differences in outcome events between COVID-19 patients and controls. And actually, we found no difference. So you can see here the incidence of thrombotic events during treatment and the incidence of thrombotic events after treatment discontinuation were absolutely similar. Actually, there were very few venous thrombotic events in the COVID-19 population, few more arterial, but the numbers are extremely small, and there was also no difference in the rates of major bleeding. You can see even better from this graphic that the few events that occur in patients with COVID-19 actually occurred in the first 3 months, more or less. And then there were no additional events, whereas few more events occurred in the control population. So actually, this is quite reassuring about the fact that we can stop anticoagulant treatment in patients with COVID-19 associated venous thromboembolism, and that these potential long-term risk of recurrent events due to subclinical inflammation, at least in our population, was not detected. And so we conclude our study reporting the fact that descriptively we confirmed that COVID-19 patients had more PE events than other patients with the VTE secondary to hospitalization that were represented in our control group. The therapeutic strategies differ between the two groups during hospitalization, but were similar. Both in the choice of treatment and in the duration of treatment after discharge, and the risk of recurrent thrombotic events, both venous and arterial, was low and similarly low in the two groups. And actually, these results confirm the results of two other studies that were published a few weeks before our study was published in RPTH. And these other two studies also report very low incidence rates of recurrent thrombotic events in patients with COVID-19, which is very consistent, of course, with our findings. So thank you very much. So this is the first page in RPTH. So we are extremely happy to have our study and our efforts published in the journal of our society.
Thank you, Dr. Agena, for that great presentation and this great study. I have a few questions for you. And before I get into that, I would like to remind our viewers on Facebook, Twitter, and YouTube to leave your comments below if you have any questions, and I'll be able to ask them during this live session. Dr. Agena, my first question was about the baseline characteristics between the two groups. So the COVID group had lower risk factors for hypercoagulability, namely chronic inflammation, history of venous thromboembolism, and CVA was higher in the control group. Would you interpret this difference between the two groups to be a result of a higher prothrombotic effect of COVID-19 compared to non-COVID-19 causes of venous thromboembolism in the hospital?
Thank you. This is an excellent question, and I think the answer is certainly yes. And we had the clear evidence that the very strong inflammatory response to the infection led to a substantial risk of venous thromboembolic events. So COVID was really a major risk factor for venous thromboembolism in these patients, especially severe COVID leading to hospitalization. And in fact, the incidence of events that was reported was higher than in other patients hospitalized for acute medical diseases. And in fact, and the population that we selected as controls had additional risk factors that contributed to the development of venous thromboembolism. So absolutely. Our concern was that these prothrombotic effect could have lasted for longer, but this was not the case. But certainly this was really the major driver for venous thromboembolism during hospitalization. I agree.
Right, and I think you mentioned in the paper that because of the small numbers of venous thromboembolism outcomes, it was hard to control for the baseline characteristic differences. Do you think this warrants further investigation into those who have a higher prothrombotic baseline risk onto whether they perhaps may need a longer duration of anticoagulation?
I think this is another excellent question, and actually, it would be very interesting, but unfortunately, we were not able to do that to also continue to measure inflammatory markers during follow-up. We don't have this information for a majority of patients, so this was an observational study, so we could not mandate these. But I agree. We could go back to the baseline data, as you mentioned. But as you also mentioned, the number of events is very low. So unless we can merge the data of additional studies, then it's really unlikely that we can come up with some meaningful results.
Right. Well, thank you for answering this question. And I think it's a good thing overall that the outcomes of venous thromboembolism were so low in the study follow-up. My second question is, so one thing I did notice is that a significant proportion of both groups, the COVID group and the control group, had duration of anticoagulation that was extended beyond 6 months. If I remember correctly, about 55% or so of the COVID group and a little more in the control group. And this makes me wonder, have you considered comparing, within the COVID group, have you considered comparing those who received the shorter duration and those who received the longer duration of anticoagulation in terms of the rate of venous thromboembolism recurrence at the discontinuation period?
This is another excellent question. So actually, yes. So there were differences in the duration of treatment, and but we unfortunately, or luckily for the patients, we had few events, and of course it's difficult to answer your question. So we went back to see if those patients who stopped at 3 months were those who had recurrence, but actually those who recurred had different treatment durations. What we observed is that all recurrences occurred quite rapidly after treatment discontinuation, but this was regardless of the duration of treatment. But you're right. These early onset of recurrences may suggest that there is still a prothrombotic effect that may act, but unfortunately, again, the event rates were limited, and the duration of treatment in these patients ran between 3 and 9 months approximately, and it's difficult to speculate on that. But the rapid onset of recurrences may suggest that these very few patients may have had some residual prothrombotic condition, regardless of the duration of treatment, which never.
Thanks for clarifying that. Yeah, thanks for clarifying that. And I think the fact that a significant portion did get 3 to 6 months, and nevertheless the outcomes of recurrence were still low is reassuring for sure. My final question to you is regarding COVID vaccination. I think, something a lot of us have wondered about is whether those who have been vaccinated have a lesser risk of thrombosis when exposed to COVID or when they have COVID infection due to a lesser severity of the illness. So do you think, given the timeline of the patient population being between June of 2020, if I remember correctly, and December of 2021, correct, do you think the impact of COVID vaccination lowered the venous thromboembolism outcomes compared between 2020 and 2021? And is that the reason why there were so many low venous thromboembolism outcomes?
That's a very fascinating question. So honestly, we did not look on the vaccination status of patients enrolled in 2021. That is a good question, but I don't have an answer, of course, right now. But this is something we can try to look at to see if there are some differences in case some of the patients had some vaccination before the events.
Right. Definitely. And sometimes it's hard to get that information if it wasn't part of the initial data set.
We should go back to. It's not easy.
Well, Dr. Ageno, I really want to thank you again for presenting your work and giving us more insight into this fascinating study. And we hope the reviewers will read the full details of the paper on our site, rpthjournal.org. And I hope you will publish again with us at RPTH. I want to thank those who have joined us live. Don't forget to follow us on Facebook, Twitter, and YouTube. And thank you for watching, and keep an eye out for the next RPTH Research Recap.
Thank you.
Thank you.